we do have currently CAR T-cell therapies. We have bispecific antibodies that look very well in terms of outcomes. We have some of these CAR Ts like ID-cell and cilta-cel that were approved in later line. Now they're approved in earlier lines of therapy, and we've seen some 5-year follow-up data from both ID-captogene biclusol and cilta-captogene autoleucel, which look very impressive, particularly in CARTITUDE-1, where we saw about a third of the patients being alive and disease-free at that time point. Now, certainly we have other products in development. So one of them is anito-captogene autoleucel or anito-cel. There will be some Imagine-1 data presented at EHA this year, 2025. But essentially, this is another BCMA-directed CAR T utilizing a D domain. So far, the follow-up is only about 12 months or 12.6 months or so. But essentially, in the study, they're seeing very high response rates, as high as 97%. And with longer follow-up, we're seeing deepening of responses in Imagine-1, as well as no evidence of non-ICANS or delayed neurologic toxicities, such as Parkinsonism, cranial nerve palsies, Guillain-Barré, etc. Beyond anito-cel, there are many other products in development. From a CAR T perspective, we have dual-targeted CAR Ts. We have trispecifics with some recent data presented at ASCO with response rates as high as 100%, which is really impressive. And certainly we have multiple bispecific combinations earlier in lines of therapy, as soon as maintenance, consolidation type of setting, that all of that looks very exciting, and we have so much to look forward to for our patients. Currently, we have, as I mentioned, multiple CAR T-cell therapy products in clinical trials that look quite impressive. So one of them is arlo-captogene autoleucel or arlo-cel from Quintessential study, where essentially we're seeing significant responses, even in prior BCMA-exposed patients. We're seeing responses as high as, in the high 80s, and the non-BCMA cohort over 90%, with a median PFS of 18 months, which is truly impressive. And the on-target off-tumor toxicities that we generally see, with GPRC5D-directed bispecific with CAR T, that rate, and the toxicity itself, generally it's more self-resolving in a majority. It's not as severe per se as it would be with talquetamab. Other products in development, as we talked about from a CAR T standpoint, we have dual-targeted CAR Ts. We have BCMA GPRC5D CAR T in clinical trial development, a phase 1 study. Currently, the study has finished accruing in the later line cohort, but certainly we'll have more cohorts and 1 to 3 prior lines of therapy. We also have the FastCAR, which is another dual-targeted CAR T, which is CD19 and BCMA. What's exciting about that product is that it looks quite good from an efficacy and safety perspective, and it's a FastCAR. We're able to manufacture it fast, and that helps with the whole bridging and waiting for manufacturing time. Beyond that, we've talked about trispecifics, bispecific combinations, etc. MRD is a very important clinical endpoint. What we are seeing is our patients, for example, treated with CAR T-cell therapy, who achieve MRD negativity early in the treatment course, for example, within the first 30 days or the first 90 days. These are the patients that are going to have generally durable responses, and they're going to have significant improved outcomes in terms of whether it be progression-free and overall survival, and studies have shown this, as well as at the recent FDA ODAC meeting. So I do think MRD is going to be very important in terms of incorporating it in our decision-making as we see novel products come to the market. As we have multiple BCMA targets, right? We have BCMA bispecifics, we have BCMA CAR Ts. We're going to have a BCMA ADC, belantamab mafodotin, approved in the UK, likely going to be approved soon in other areas. And then we have the dual targeted CAR Ts that have BCMA as well. So certainly we are learning more and more about sequencing. Currently, we have a little bit of clinical trial evidence from a CAR T standpoint, CARTITUDE-2 cohort C, and then we have some post-CAR T bispecific use and Majestic-1, Magnetism-3, etc., and Balcatamab studies, monumental studies as well. But essentially what we are seeing is that if we specifically focus on the BCMA exposure, patients who've had prior BCMA exposure are more likely to have inferior outcomes with a subsequent BCMA CAR T. And there are some recent guidelines from the International Myeloma Working Group stating that if all else is equal, including access, ideally a BCMA CAR T is preferred before other BCMA agents, such as the BCMA bispecifics. And then we also have data, as I mentioned, from the clinical trials and real-world evidence showing that, a BCMA bispecific could be utilized post a BCMA CAR T. Certainly, the response to the prior BCMA agent, the depth of response, and the durability of that response matters. But that generally is the preferred approach. The landscape is evolving, right? Bispecifics are likely to come earlier in lines of therapy. So I think we need to stay abreast of the new development and more data to come as the treatment paradigm continues to evolve. Anytime we develop novel therapies, we're still talking about an incurable disease, though the CARTITUDE-1 data looks very good. Our patients still relapse. So I think identifying mechanisms of relapse is going to be very important. Considerations such as T-cell exhaustion and dysfunction, a suppressive tumor microenvironment, as well as consideration for antigen loss by mutations, more so for bispecifics than for CAR T-cell therapy. And also, we want to optimize safety for our patients. So considerations for non-ICANS neurotoxicity, cerebellar neurotoxicities, we need to be able to identify who these patients might be. So predictive modeling will be very important, but also prophylaxis strategy to help prevent these type of toxicities. And then certainly we want rapid and reliable manufacturing ultimately so that we have the most efficacious product with a durable response, as well as one that is safe and is produced rapidly and it's reliable. Certainly there's another bispecific antibody, the FcRH5, cevostamab, in development that has been used in prior BCMA patients with over 50% of the patients, and the results are encouraging because that's yet another new target that we can utilize in the treatment paradigm for multiple myeloma.